Good afternoon. I'm Carlo Di Mario from Florence. Unfortunately, my co-moderator didn't manage. James Pratt, you know that there is snow in London right now, and I guess this is the reason why his flight didn't manage to get to Dubai in time. But he will connect, and hopefully he already seeing us. The two people that you see besides me are well known, I guess, to most of you. Dr. Gindi, who will co-moderate with me, and Dr. Noor, who already had a beautiful session on CTO. And I think this is the second biggest challenge in interventional cardiology after CTO, treatment of heavily calcified lesions. And we are trying to discuss a novel method, intravascular lithotripsy, and the best way to achieve results. In the title, we have written what's the evidence, and I will try to start by showing you and sharing with you some of the most recent results from the DISRUPT pooled meta-analysis. So I will just move over there to share my slides. So these are my conflicts. I was the PI of DISRUPT 1 and 2, and these studies, this family of studies has finished almost 2 years ago, but still there are, I believe, quite a lot of interesting data coming out of these 600 plus patients. And I will focus mainly on the results of around 1/3 of those patients, the 262 patients for whom we have a complete OCT analysis that was consistently done by the Cardiovascular Research Foundation Laboratory. Excellent work by Ziad Ali and his colleagues in New York. As you know, these are lesions that were selected purely based on angiography. You wanted to see a rail of calcium, facing calcium in vessels between 2.5 and 4 millimeter. However, some of them didn't prove to have a greater than 180-degree continuous arc of calcium. That is the definition that we normally have of a concentric calcified lesions. Maybe there were small speckles of calcium opposite, but also angiographically, the core lab confirmed the presence of this rail of calcium in almost all cases, but OCT showed that 56 out of these around more than 220 cases had a less than 180-degree maximum continuous arc of calcium. They had similar severity of lesions in terms of minimum lumen area and area stenosis. Obviously, the arc of calcium was smaller, 131 versus a growing number coming to the Napkin's ring in the last quarter. The thickness is similar. You are all aware of cases where you may have purely eccentric calcium, but an extremely thick, difficult to expand plaque. So for these particular eccentric calcifications, is the use of intravascular lithotripsy equally good? Looking at the presence of visible calcium fracture, the initial idea is possibly not, because you see them only in 23% of cases versus almost all cases, 97%, when you have a Napkin's ring of calcium, which is obviously the main target that you want to approach with this technology, since you have no alternatives besides rotational or orbital atherectomy. Also, the number of fractures that you have when they are visible per lesion is lower, 1.3 for eccentric versus up to 4.5 for Napkin's rings. Expansion is similar. You may say, well, then nothing happened. It's just expansion in the normal part of the vessel wall. Even if the stent area is similar, and the stent expansion compared with the reference segment is excellent, greater than 100%. Not necessarily your device has done a great job. I think we have probably to get more data for that, because what we have learned is that expansion and maximal area is not, as we expected, related to presence and number of calcium fractures visible, even if you use the best possible technique for that, the one with highest resolution, OCT. We have evidence that you may have some fractures nearly invisible or totally invisible with OCT, like in this calcium nodule, where possibly some thrombus is obscuring the outer wall, which with micro CT you detect presence of multiple fractures. These are images before and after intravascular lithotripsy. So I think this, in my view, makes the question of when and how to treat eccentric calcification with intravascular lithotripsy very open. But the main topic I've been asked to cover is female versus male treatment of calcium, because we have evidence from a very large study that female patients have much worse outcome when they have moderate to severe coronary calcification. Name one of the complications from, well, death, MI, target lesion revascularization, even a rare event like stent thrombosis, not significantly, but is higher when there is a moderate severe calcification in women. And women tends to do worse than men when we use the conventional tools that we have at our disposal. Rotational atherectomy, 765 patients, and you see the percentage of bleeding, coronary dissection, and perforation leading to tamponade that is 5 times higher in women than men. Smaller arteries, very tortuous arteries, these are probably the reason explaining these higher risk of events. You see from this comparison of the 144 women enrolled in the pool meta-analysis versus the 484 men that they were slightly older, they had multiple risk factors, 41% with diabetes, 32% with renal insufficiency of previous interventions. And if you look at the procedural characteristics, you do have application of similar, slightly lower number of pulses. And in fact, that's the normal technique. Quite rarely predilatation was required, around 40% to insert the IVL catheters. After IVL, there was hardly ever post-dilatation before implanting stents, but there was consistent post-dilatation at the very end of the procedure after stent implantation. You see slightly more frequent use of radial in men than women. And these were the results, with almost no major complications if we set relatively minor dissection, and again extremely low percentages both in men and women, with the only perforation occurring in men after post-dilatation of the stent, not due to intravascular lithotripsy. If you look at the events in hospital, but the 1 year you don't have additional events explainable by the procedure performed, you see that they are almost all non-QA myocardial infarction. Increases of CKMB more than 3 times was the SKY definition that we applied, and there was a similar percentage, relatively low, in men and women. When people ask for randomized data, we shouldn't forget that we have a randomized trial, the peripheral PAD 2 trial, comparing superficial femoral arteries intravascular lithotripsy with conventional technique and showing with intravascular lithotripsy, we can have fewer need of implanting stents. We have, however, a much larger trial, the PAD-3 registry, and in this you have 377 women versus 885 men, old, 56% diabetic. When we speak of renal insufficiency, you are really speaking of something serious. More than 20% are on dialysis, many of them as concomitant coronary artery disease in need of intervention. Women tend to have more often disease going to relatively smaller vessel, fewer iliacs and more superficial femoral. They had, as you can see, a very low need of usage of stent to cover slow flow and major dissection. Intravascular lithotripsy at 4-6 atmospheres can achieve a sufficiently large lumen, as you can see here, to avoid the use of what is a potential risk of events like implanting stents in an area where there is bending, where there is a risk of compression, where there is a risk of rupture. And you see how with this minimal use of stent implantation, a large lumen was achieved after IVL, and not much difference with the final outcome at almost no price in terms of complication. You tend to be more aggressive in the periphery, but still look at the number of dissection or perforation. So my conclusion on this topic is that based on the pool meta-analysis, which is the largest sex-based report of intravascular lithotripsy, we have confirmed excellent procedural safety and effectiveness both in women and men, and this contrasts with the prior reports on different techniques, which potentially lead to catastrophic complication more often in women. And there is confirmation from a large peripheral series suggesting that intravascular lithotripsy should be considered a first-line treatment for calcified plaques in women. Thank you.
Thank you very much, Carlo. Insightful as always. So any questions from the floor? I think while the audience perhaps prepare the questions, it's interesting how there is a mindset that IVL works perfectly well once you have a near circumferential arc of calcium. And I think the reason you've shown is because the current tools we have to measure response to therapy are fixated only on imaging fractures, on seeing fractures on intravascular imaging. Now, it's also interesting to see on the same slide that this did not have an immediate or a direct impact on the degree of stent expansion at the end of the day. So my question to you is, do you think that, A, does IVL work in non-circumferential calcification in 270 arcs, for instance? And is the limitation here about how we assess response to therapy currently, and do you think we can improve it? The second question is something that will always keep arising. What happened to the cohort with calcified nodules in DisruptCAD? So I know there are interesting data coming up with you and Ziad. How is that working? And are we only looking at calcified nodules versus nodular calcification? How do you see it?
Yeah, I mean, we do have a separate report on calcified nodules. You possibly have seen it presented at TCT this year. I couldn't, because of time, go through all the data, but some of them are certainly within those eccentric calcification that I presented. Also, nodules tends in general to have a more concentric and greater amount of calcium than 180. Well, first of all, I think that we have still to work on confirming that intravascular lithotripsy managed to gain area and improve outcome in purely eccentric lesions, because while for the others there is no alternative, you know that you are going to get with a grossly under-expanded stent if you don't use any atherectomy or lithotripsy technique. For an eccentric lesion, you may hope that just expanding the normal part of the vessel does the job. You will get a not so pleasant kidney-shaped appearance, very oval deformation of ovular deformation of the vessel. However, you may get your lumen at the end of the day. My experience is that you manage to get much more circular. You can avoid the extreme pressures that sometimes lead to disasters in these cases. Rupture of vessels, unless you are consistent in doing ultrasound, and sometimes even if you do ultrasound in this extremely eccentric lesion, you may rupture. While at 4-6 atmospheres, if you manage to modify the calcium before, you will achieve safely a better result.
Hossein, we have a question from the floor.
Just a short question, actually. A technical question. Suppose you use IVL and you obtain suboptimal result. How far and how frequently can you repeat it without having the risk of developing complications?
Well, I don't think there is any risk of complication in doing as many passes of an IVL catheter as you wish. The only risk is for your wallet. It will be a very expensive procedure. I think the main reason why you are not getting a good result with intravascular lithotripsy is that you made a mistake in selecting the balloon size. Because if your size is not large enough to reach the wall, the effectiveness of the shock waves is minimal.
So how many times can you reapply in the same setting, in the same patient?
Well, again, normally you don't need to reapply. The only reason why you tend to use maybe 2 balloons in the same lesion is because it's so long that you can't really distribute it in an appropriate fashion. If it's 10 centimeters, I don't think you can do it with a single catheter. First of all, because there is some tapering, so balloon size is different. And second, because you need more shocks delivered, irrigation delivered. Right now, we will soon have newer catheters with 120 activations instead of 80, which I think will help to also contain costs. Hopefully will arrive soon. As you know, for peripherals, you already have 300 erogations per catheter, so they are thicker catheter and you don't have a risk of rupture, and you can get an excellent result.
Thank you.
I don't think there is a risk in applying it as many times as you want. It's not like the one pass too much of the rotational atherectomy catheter where you cut the wall. That's not the case.
What would be your maximum pressure to use?
I think pressure is not the issue. What you should see is go to very low pressure. Often I start at 2-3 atmospheres and see that remains very indented. Don't change the pressure, and just starting to activate the catheter, you see it expanding. The only thing you should do with your catheter is after the second or third times you do it, if you see bubbles, that is quite often, take them out, because that makes the homogeneity of the erogation worse. But I don't think you should go at very high pressure unless you want to use the compliance of the balloon to get to a slightly higher size in the proximal segment. Personally, I hardly ever go above 6-8 atmospheres.
So we have another question. Sorry, I think just to highlight what Carlo is saying, the whole concept is you don't want higher pressure. With non-compliant, if you go high pressure, you're sort of gambling on one thing, that rather that the calcium is not going to go anywhere. you're gambling on expanding the adventitia on the other side, on the non-calcified side. And then comes the question, how compliant is that? And this is where you start running into a problem, because we don't have a true answer. So you can get away with 24, 26, no PN at 40 atmospheres in one patient, and in the second patient, you end up with a vessel rupture. So with shockwave, the whole concept, if you have good contact, you don't need the high pressure. And this is where the safety comes from. And this is where Carlo is saying, it's safe. You can do it repeatedly over and over again. But for the sake of time, we have Dr. Haitham.
Yeah, Dr. DiMario, what's your take on IVL and calcific nodules? How can they modify calcific nodules to basically help in getting better stent deployment and better stent apposition?
I mean, you've seen that impressive image with a micro CT of a calcified nodule and broken. I think these are extremely difficult lesions to expand with any technique. There's been claimed that possibly orbital atherectomy, since it managed to get to the calcium, may have a better outcome. Rotational works when the bias is against the nodule. If it doesn't, it's very difficult. I think our experience is not enormous, because this RAP study was not in nodules but in facing calcium, right? However, what we have from the 100 and so nodules that were in the study suggests that you can achieve good expansion, and we are now less worried about inability with OCT to see fractures, because these are so small that in this difficult milieu, even OCT is unable sometimes to show it. Still, the vessel opens up. Still, the lumen is obtained, which is different from using just high-pressure balloons.
Just one comment. They are difficult structures, but what we're starting to learn is calcific nodules are not the same. They differ in shape, but they also differ in composition as well. And whether you're talking about an eruptive type or you're talking about solid calcified nodules with hardly any necrotic core and with a lot of calcium volume, now those are obviously different animals. But I'm sure that James will hopefully, because he's sort of dissected that in depth, give us some more insight. But I don't think we have the perfect solution.
Maybe another point to mention, is 5% of unstable plaques, including STEMI, due to calcified nodules. This is a nightmare, because you can't do with a high thrombus burden rotational atherectomy or orbital atherectomy. That's your only option, and at low pressure you can achieve, but so far the best we have.
So we're keeping James online, but I think there's one quick question from Hossein, and perhaps can we keep that till after your question, till after James's talk?
Just follow up on that is in the pipeline, are we getting longer shockwave catheters for lesion? The ones we have is short sometimes. I understand it's going to be difficult to deliver it distally for the, let's say, osteo-LAD, osteal-circ. Sometimes you need longer. That's one question. The other quick question, going back in time, in the old times, I would say, there was the DCA, in which, it does the directional cut. Do you think, because there's a lot of discussion has been among my colleagues, we talk more about the nodule, do you think there is a potential use of DCA coming back, in which would take care of the nodules in the osteo-LAD or proximal RCA? I know it's going to be very difficult for distal down, but in these specific areas. You have a lot of experience with that. I want to hear from you.
Well, I think we should get one of those few Japanese colleagues who still have a DCA catheter available, a sort of copycat of what we had 20 years ago on our shelves. I confess, the last DCA catheter, as you know, was supposed to be effective also on calcification. That was not much of my experience. I really think these are extraordinarily difficult lesions to treat. And the main advantage of the techniques we use for calcium is the differential effect. So it works cutting or rupturing the calcified plaque, but without damaging the normal part of the wall. Whatever is done differently, like with a blade, I don't think has the same chances to be safe.
Thank you very much, Carlo. I think James is online, is waiting for us now. James Pratt needs really no introduction. If you're in the CTO space, if you're in the calcification, intravascular imaging, but if you also want to sit for a very good presentation, then you must know James. James, it's a shame you can't join in person, but thank you for making it possible to be online. The floor is yours.
Yeah, thank you, Ahmed. I'm very disappointed not to be there with friends. I've heard some great comments already. It's clearly an area where there's a lot of intense research, a lot of areas that we still have to fully understand. And some of the comments from the audience sort of try and capture some of those conundrums that we're facing. So I hope to address some of those within the context of this presentation. Thanks to Optima for the imaging support. If people want to connect to me, that my Twitter handle is there. I think this first image captures a little bit of the confusion around calcium that we're trying to decipher, take all that noise away, create a signal, and then put that signal into connection. What does it mean for your patients? What are you going to change in your practice from what you've heard from Carlo, Ahmed, and Hussam, and hopefully me today? And those are my financial disclosures. Clearly, this is sponsored by Shockwave. But let's start with the basics. Calcium is challenging. Is imaging essential? And I think it's worth asking ourselves these questions. Is plaque modification more likely in calcific coronary disease? Are complications more likely? We've heard that from the floor already. The concern about complications. Is stent failure more likely in calcific coronary artery disease? And how can you maximize the value of imaging? So is it truly essential? And if we drill down to what essential means, it means either absolutely necessary or extremely important. And a thing that is absolutely necessary. And I'm hopefully going to convince you today that imaging is one of these key components of ensuring a good outcome for your patients in this challenging subset of patients. And there's a lot of data showing that calcium is a marker of stent failure. So this is a cumulative incidence of stent failure extending out to 3 years. You can see that when we quantify calcium in terms of severity, that severe calcium means a higher incidence of stent failure. And that's one of the key questions. What is the threshold of care? When do you need to move from simply balloon-based therapies, which you're all very familiar with, to calcium-specific therapies? And I think Carlo and Ahmed and Hussam were starting to tease out that threshold of care. What's going to push you into selective forms of calcium modification? So let's start with a coronary angiogram and ask ourselves the question, is detection of calcium limited by coronary angiography? And the short answer is yes. Coronary angiography is insensitive at detecting coronary calcium, but again, there is a threshold of care when that matters. So we know that if we get very concentric calcium or nodular calcium, if we don't prepare these lesions, the stent is much more likely to fail. And you can see from this schematic that even when there's circumferential calcium, the angiogram misses it in about 15% of cases. And of course, that really matters to the patients that you're treating. So think of this angiographic assessment as the gatekeeper of therapy. So if you don't see angiogram or calcium visible in the angiogram versus if you do see it visible in the angiogram, it's going to change when you're going to really maximize the value of imaging. If you don't see any calcium, it's less likely imaging is really going to make a difference. If you do see calcium in the angiogram, imaging is going to be critical. So let's look at a classic angiogram picture. You can see there's severe tram-line calcification there present as indicated in the calcium. And the first key learning point I'd like you to take away is that the morphology of calcium is not something you can delineate from a coronary angiogram, but its response to therapy can give you critical information. And what I'd like you to look at here is the deviation from the middle, the wire from essentially being in the middle of the balloon, there's a point in the middle of the balloon where the wire is biased towards the calcium. And so you can infer that there's a nodule there from its response to therapy, if you like. So if you look at a coronary angiogram and you can see angiographically visible calcium, that tells you that your minimum stent area is at risk if you don't modify that calcium. And it's not a small difference. You can see at the bottom in terms of MSA, you've got an MSA of 8 millimeters squared when you don't see calcium, compared to an MSA of less than 6 when you do see angiographic calcium. So lesson number one, if you see angiographic calcium, that means you need to get the imaging tools out so you don't see an underexpanded stent like this. Because calcium inhibits stent expansion, that seems like an obvious thing to say, but that's the reason why it really matters to us. So why does it inhibit stent expansion? Well, the answer is it's non-compliant. So unlike the normal structure of an artery, calcium is inelastic and rigid. So it doesn't stretch. If it doesn't break, it doesn't modify at all. And that compares very differently to a normal arterial structure, but it also compares very differently to other forms of plaque. So fibrotic plaque will have an elastic component to it. And the major issue you're dealing with there is recoil. The balloon may expand, but the vessel may contract afterwards. Whereas hypoechogenic plaque or lipidic plaque is very compliant and it stretches very easily, and you very rarely need to modify those lesions. But critically, the thing about calcium that makes it really different is its confluence. So it's not just spotty calcification, actually has very little impact on vascular compliance. It doesn't really make any difference at all. But as soon as it becomes confluent, i.e. it forms plates, then the artery compliance drops and it's resistant to expansion. So what we're trying to do with coronary calcium is to fracture it. And these fractures create channels and they allow the plates of calcium to move apart, and therefore the stent being expanded. And that gets on to some of the questions that have come up already. How do you know when it's worked? And one of the questions that came up was, if you don't see fractures, does that matter? And sometimes the reason you don't see fractures with lithotripsy is that the fractures are in a crazy paving type effect. So they're not all in the same plane. And when they're not always in the same plane, you can't always see them on imaging. But it's really critically that the confluence and the volume of coronary calcium that predicts total vascular compliance. So this kind of patchy compliance doesn't matter that much. When it starts to form arcs, or particularly circumferential patterns of calcium or nodules, then it really does matter. And you can see what this looks like on imaging here on IVUS and here on OCT. And now clearly the critical difference between IVUS and OCT is actually the sensitivity of calcium is slightly higher with IVUS, but it's unable to characterize the volume due to reflection of the ultrasonic wave, whereas the OCT can tell you the volume of calcium. And critically, we focus on these circumferential areas and we say they're really important, but it's not just circumferential that's important. It's the volume and how long that circumferential area extends. So a short circumferential lesion is much less important than a longer circumferential lesion. So you must assess your calcium across the longitudinal part of the vessel, not just in an axial projection. So if we look at our OCT scoring system, for example, it does this through 3 key factors: the length of the calcium, the thickness of the calcium, and the angle of the calcium. And you get a scoring system which adds up to 4, in which the angle of the calcium is overweighted. So in other words, you get 1 point if it's less than 180, you get 2 points if it's more than 180, and you get up to 4 points. And when you add those points together, once you get to 4, as you can see in red here, that really starts to matter in terms of how it's going to affect stent expansion. There's a similar scoring system to calcium. And again, it's the concentricity of calcium. Nodular calcium, as we've heard already, remains a real point of concern. And critically, and particularly relevant to Carlo's talk, the vessel diameter also matters. And that's probably why you see this adverse outcome with female patients. They tend to have smaller vessels. And smaller vessels means it's more difficult to get the stent to a size in which it's not going to fail. So your relative MSA becomes more of a limiting factor. And of course, length of calcium as with OCT. So is it possible to assess the efficacy of plaque modification without imaging? And then here, it's really important to understand that balloon expansion does not equal lesion preparation. And again, Ahmed touched on this already. You can get expansion of a balloon, which expands the elastic part of the artery, i.e. the adventitia, and doesn't modify the calcium. And this is particularly important in eccentric or nodular calcium. And that's where the risk lies. Ironically, where you see concentric disease, it's more easy to predict whether the lesion is prepared or not, because with a balloon, you get this still circumferential expansion effect. So if it expands, you know the lesion is probably cracked. If it doesn't expand, well, you know, you need to do something more. So the risk of concentric calcium is actually lower than the risk of eccentric or nodular calcium, which is a really important fact to take away. And when you do put a stent in, is it possible to assess the stent result properly without imaging? And I think the answer is no here, because our goal is minimal stent area. And I think the way to think of minimal stent area, it's your luminal reserve. You need to get the stent as large as you can safely so that it can survive any subsequent kind of degree of neoatherosclerosis or neo-intima. And there's a lot of data showing that MSA predicts stent durability. And there's lots of different ways to characterize MSA. One is the absolute area. And the second, and probably the more important way to characterize it, is the relative MSA. In other words, how well does it match the optimum size of the vessel? And again, that comes back to the risk of stent failure is higher in smaller vessels for that reason. So safety is really top of the tree when we're treating patients. We want therapy to be safe. So we have to ask ourselves the question, are acute stent complications more likely in calcific coronary artery disease? And if so, why? And again, this is down to adventitial stretch. When we have a volume of eccentric or nodular calcium and we try to modify that with balloons, what happens is the elastic force is directed towards the stretchy part of the vessel, and you don't get any modification in the inelastic or the calcific part of the vessel. And if you choose the wrong size or you oversize the balloon, that's where perforation really comes into play as a major risk factor, which you want to avoid. A lot of questions already about calcified nodules. I absolutely agree with everything the panel has said already. They're challenging areas to treat. They're very challenging lesions. There's a fair degree of heterogeneity among these lesions, which make them very difficult to understand. Because there is a degree, even with imaging, our understanding of nodules is not perfect. Because we don't really know what lies underneath the surface of the calcium. And as Ahmed has touched on already, that could be a necrotic core. And you could think of that a little bit like popcorn. If you just crack the lesion, it'll collapse because the foundation of the nodule is relatively soft. Or it could be like a hard-boiled sweet where it's like solid and very large, and therefore it's very, very difficult to modify. But what you do not want to do is to rely on balloon expansion only. And if you're going to use a balloon, you need to start with a non-compliant balloon, because if you use a compliant balloon, as you increase the pressure, the balloon size also increases, and you get this area of danger where the balloon actually is much bigger than you thought it was at higher pressure. And that danger zone is where you're going to really risk perforation. So I'd say top of the rules for treating calcified nodules is don't use compliant balloons. And if you're going to use non-compliant balloons and not go for selective calcium treatment, be very careful about the sizing. And where the risk is going to lie is the volume of calcium and how the calcium responds in terms of what its foundation looks like. Is it a relatively soft necrotic core, or is it solid all the way down? And remember, if you put a stent in an unmodified area, this stent can only expand in one direction. So once you put the stent in and you've failed to modify the lesion, you've missed your opportunity and your risk still remains. Having a stent in place does not make this artery any safer to treat. And if you overexpand that stent, you're going to get the same problems with perforation that you would have with a balloon before you put the stent in. But if you look actually in terms of how shockwave is performing within nodular lesions, actually it's performing pretty well. And this is data from the studies that Carlo was one of the principal investigators on, that's showing in terms of expansion, you get pretty good expansion. Now, there is a question that remains. Is expansion the only question with calcified nodules? Because this is not a talk on nodules. And there's, of course, as Ahmed said, there's a whole long discussion about the mechanisms of nodules, how they started in the first place, whether they exist at points of torsional force, and whether that torsional force is adequately treated by stent expansion so they can come back. But what I would say in terms of lithotripsy is that the early results are very encouraging. It's very safe technology, and good stent areas can be achieved very, very well. So again, it's worth asking ourselves, what are the mechanisms of dissection in calcific coronary disease? And top of the list of mechanisms of dissection is if you land stents within plaque. So one of the key things that imaging will add is the ability to understand where the plaque is, so you can prepare the plaque and you can cover the plaque and you don't land your stent in the middle of the plaque. As well as MSA being a marker of outcome, geographic miss, in other words, landing your stent in plaque, is another key area of reason for target vessel failure. But again, there was a question from the audience, and probably the most in question so far is safety. There are quite a few therapies out there for nodular calcium. We've got rotational atherectomy. It's an ablative therapy, so it works if it touches the nodule. If it doesn't touch the nodule, as Carlos said, it doesn't work. There are ways to modify wire bias to address that, but sometimes that could be very challenging. The same could be said of orbital. It is also affected by wire bias, and again, the data is not very convincing about its effects within nodular calcium, but maybe that's because we haven't asked the question properly. But what we can say is that IVL is an incredibly safe therapy. So you've got examples here again from the pivotal CAD3 study showing very low incidence of any problems whatsoever, very low incidence of dissection, perforation, abrupt closure, or slow flow. And again, if you compare that directly with orbital, you can see in terms of angiographic outcomes, in terms of MACE at 30 days, it compares very favorably. So having safe therapy is absolutely foundational. And then, of course, after safe, you want it to be effective. And again, getting back to a couple of questions from the audience with respect to threshold of therapy and dose of therapy, there really isn't any risk of giving further therapy if you don't get an immediate response that you're after. As Carlos said, the only risk is to your wallet, which I liked. So I would say that the intravascular imaging allows safe implantation of a larger stent, and a larger stent is what's going to give your patients a durable outcome. And I think you need this scaffold of learning in terms of how you approach the lesions. You start with calcific assessment, you prepare the lesion according to morphology, and you optimize the stent according to the imaging characteristics that you see. So the key messages I'd like to leave you with today is that calcific coronary disease is complex. It needs this kind of sharing of knowledge bases across specialities and geographies, and Shockwave are to be thanked for supporting this meeting today, which I'm very sorry to be missing and struggling through the cold in London. But the goals of intervention are just the same. They're just more challenging to achieve. That compromise leads to complications. That when things aren't working, you don't just repeat it at a higher pressure. You understand what's going to take, what it's going to take to modify the lesion in a safe and effective way. And as the complexity of treating these lesions increases, then the value in turn of imaging also increases. So thanks for your attention, and I'd be very happy to take questions with the following remit: that imaging improves safety by reducing risk. It maximizes efficacy by identifying the need, i.e. the threshold, and the success, how well you've modified the lesion of plaque modification. And finally, it's all about durability. Success is not defined by what the result looks like on day zero, but how well the patient does in the years into the future. Thanks for your attention.
Thanks.
So one of the best talks I've ever heard on calcium, and so lavishly illustrated. Every time James does it better. I mean, we miss him in person, but you gave a fantastic talk. I see already lots of hands rising. Please.
Yeah, I have one small question. Since the device is expensive, and sometimes it doesn't cross the lesion, so how can you improve the success rate of crossing the lesion? And instead of taking the balloon and it's not working, so you just throw it, and it's a lot of money to throw.
Yeah, so I mean, that's a good question. And I think that comes down to the algorithm, how you treat calcium. And I think every device has its good points and its less good points. Shockwave is limited by the generation of the shockwave itself. And that makes the balloon bulkier than a normal balloon. So it's not so good at crossing critical lesions. So we say that if you have got a critical lesion, that's the role for rotational atherectomy. Rotational atherectomy is excellent at crossing critical calcific lesions. We're all very familiar with it. We've had it for 30 years. It works very well. One of the other mechanistic basis of shockwave treatment is that when the balloon is compressed, it works less well. So it actually, in terms of delivery, it's not as good as rotational atherectomy. In terms of efficacy, it's better placed where you can place it across the lesion without having to shove it in too much. Now, I would say there's clearly ways you can make delivery of the balloon better in terms of using guide extension, etc. But if you can't cross a lesion with a non-compliant balloon, you're going to rotational atherectomy. Even before lithotripsy was around, things haven't changed now that lithotripsy is around. Just think of it as a slightly bulkier NC balloon. And if you see a case where you think, well, my NC balloon's going to struggle here, then that's the case to start with rota, then reassess with imaging. And if you haven't modified the lesion significantly, or there's deep wall calcium that you know the rota won't address, then that's the time to deploy your shockwave balloon.
One more question from the audience?
Yeah, so when you go through all the cycles and you still have a waste on your shockwave balloon, what's the likelihood that when you follow with an NC balloon that it's going to crack the lesion?
I would say low. I think shockwave is incredibly disruptive technology. You know, I think we're lucky to have it as part of our armamentarium at the moment, but it does have limitations. I think if the volume of calcium is very, very high within the vessel and it's non-compressible, in other words, it's solid calcium, there probably still is a role within that lesion of debulking. Now, we haven't talked about debulking for several years because we sort of changed how we were using rota because of concerns of complications, but where the volume of calcium is very high, remember, calcium is non-compressible. So if it's very high, think about volume reduction first of all. But in terms of efficacy of therapy, I think IVL outperforms any other form of non-compliant balloon. And with that, I include very high pressure balloons, such as, you know, the name escapes me, the OPN, thank you. The OPN balloon that goes to 50 atmospheres. You know, I would say IVL is considerably more efficacious than that. So if it's still not dilating after you put in 80, or we now have the 120 pulse balloons, that's very rare, and you should consider volume reduction.
Thank you, James. I think we should move to the last presentation.
James, this can stay forever. I mean, there are many questions, but we're running out of time and they're about to kick us. But thank you for an excellent presentation and for an amazing deck of slides as well. It makes everyone's presentation look pretty primitive. Thank you, James. Look forward to seeing you soon.
This is about the evolution and calcium modification. And it's going to be a case-based approach, and I think I want to share with you those cases. So we have heard from my colleagues about the utility of imaging, and I'm not going to go through this. It's very important to keep in our head the calcium scoring, and that would tell you an objective way of assessing how much calcium you have and for the need of the calcium modification. And also, IVIS, of course, would tell you the delineation of the true osteum, and in the case which is going to come, the extent of the funneling, and if you do osteal disease, and stent sizing, etc., etc. And I think this is no surprise to all of us in here, the utility of using intravascular ultrasound to look at your outcome, which expands up to now 8 years down the road. So it's beneficial to use IVIS in your cases. So this is a case in which you have, I don't know if this video is not working. So you have an osteal RCA and you have also proximal RCA lesion, and as was alluded to, sometimes you'll be fooled angiographically in assessing the calcium, but if you look at this IVIS on the right-hand side, in the proximal RCA, there's also almost 270 degree of calcium, and if you pull back and you can see the osteal RCA itself has significant disease and calcified. And the question would be, what calcium modification technique you will use in a situation like this? So this is how it looks before. This is a big vessel, osteal disease. IVL was applied, and then, of course, the magic thing that everybody looks for, if you have a calcium fracture or not. And in this example, you did. And unfortunately, the video wasn't working. So osteal disease, one of the challenges of osteal disease, osteal RCA, if you think of doing, for example, rotational atherectomy, is not the best, and neither as well for the orbital atherectomy. The advantage of big vessel using this IVL is that you can put it precisely and avoiding the wire bias or wire prolapse and stuff like that. In my own practice, I would say, one of the advantages which I've used intravascular lithotripsy is calcified large vessels. I mean, that's one of the main advantages, like very proximal RCA, osteal LAD, osteal circ, and that does work well. And this is an LAD gentleman with, fortunately, it wasn't working, the video's not working, so maybe it's, so you can see there was an osteal LAD lesion proximal to the stent, and then we have applied a 4 millimeter shockwave balloon, again sized by, and I think the key factor is you need to size the balloon by using imaging. And a lot of people, a lot of colleagues, for example, have seen you spend this heavy pockets balloon, I would quote it inappropriately sized, in which you will say, well, I haven't got a good result. So we need to use imaging such as IVIS to assess what size IVL balloon you will use prior to utilizing that to modify your calcium. This is a 4 millimeter balloon. You can see there is still a waste, and after multiple pulses of this ultrasound waves, this was able to give out. And you can see that on this image in here. And when you do the IVIS, you can see there's also a fracture on the pullback. And I think this is, for me, and I'm talking about my own personal experience, this is very rewarding when you have, especially, I mean, you think about it, where are those big, large vessels, right? It's either proximal LAD, proximal RCA, and these are the vessels that would give you trouble down the road, years to come, restenosis, thrombosis and whatnot. And those could be potentially, if not from the morbidity standpoint, from the mortality standpoint. And if you want to achieve and have good results, you need to really respect these lesions. And then it was followed by stenting and post-dilatation. And the circ has some plaque shift. IFR was done, and IFR was insignificant. I think this is the most interesting one, is in CTO scope. You see there's a medially CTO, there's calcium there, and you see the huge large branch diagonal coming off. And so try to wire that with an antegrade wire escalation, stiff wires, nothing goes through, and again, it's because of the calcium. And you can utilize the IVL balloon, sizing it against by IVIS, in which you can deliver those shock waves, ultrasound energy to crack or modify the CTO the CTO proximal cap, utilizing the shock wave going from the main vessel into the side branch. And after that, you're able to go back now to penetrate with the same wire, which you would not be able to do that before, with a guy a second, go distally, verify that you're intravascular, inside the vessel, not, as OIH say, outside. I don't know if he's here or not, he's not here. And then this is the concept behind it. You do that and you cross. And I believe I heard from James, we were discussing this case before, we went online. And I believe there's in the pipeline, they're gonna come with the IVL catheter in which you have upfront transmission of the ultrasound, which help us in these in CTO cases in which you have very heavily calcified proximal cap lesions. With that, I thank you again for your attention, and we're happy to take any questions.
Thank you, Hussam. I think we're already late in time, so Dr. Carlo.
I'm afraid we have to come to a close. We are a little bit beyond time, but I hope you enjoyed this session. I try to share with you some new data coming from the pool meta-analysis. We enjoyed this lavishly illustrated, beautiful presentation from James Pratt and the nice cases of Dr. Noor that I think illustrates the utility of these in some novel application for CTO modification of the proximal cap, but also treatment of what matters most, osteal stenosis, severely calcified proximal vessels. So it's a novel technology. We still don't know everything about it. It's 5, 6 years old. We understand that calcium is a powerful enemy, not always is sufficient. You may use complementary techniques. Rotational atherectomy is not over, is not dead by any means. We don't want to say that. However, I hope that we have tried to convince you that this is the technology that works and that we will be using more and more in the future. Thank you.
Thank you.